Hi everyone. Welcome to the part 3 of the antenatal care, and this is a very important part because in this part we are going to talk about how to examine an antenatal patient, what investigations you have to do and what advice you have to give in. Now, initial 10 minutes of this video are only for the undergraduate student because as an undergraduate student, this is one of the very important cases, and that is an antenatal patient. An examination of antenatal patient is very important. So I am going to discuss with you the examination of an antenatal patient in detail so that if you get a case on an antenatal patient, you don't make any mistakes. After 10 minutes will come we are going to talk about Leopold's maneuvers. From that point onwards, from Leopold maneuvers onwards, this video is important not only for undergraduate students, for the NEET PG aspirants, for INI set students, and for foreign medical graduate students as well. For foreign medical graduate students, generally you get one question from this video. Definitely you are going to get in the exams which you are going to give, right? So coming to the examination of the antenatal patient. Now, first thing is general physical examination, and then we go on to breast examination, and then we go on to the per abdomen examination, right? In general physical examination, first thing you have to measure and you have to mention is the present weight of the mother of your patient. Now, this present weight, it is not only the current weight or present weight which is important. You should also ask and mention whether the patient was able to tell you about the pre-pregnancy weight or not. And if this is not her first antenatal visit, and if she has an antenatal card, look at the antenatal card and see when she earlier came to you what was her weight and how much weight she has gained during this period. Right? All these things you should mention in the examination findings which you are going to tell. Number 2, you are going to measure the height of your patient in centimeters. Height has also got significance in OBS. Why? Because if your patient is short-statured, then there are increased chances of cephalopelvic disproportion. Now your examiner is going to ask you, define short stature for me. So in Indian scenario, we say short stature is when height is less than 140 to 145 centimeters. Right? So if height of the patient is less than 140 to 140 centimeters to 145 centimeters. So if height is less than 140 to 145 centimeters, then we have to suspect cephalopelvic disproportion. Then you are going to calculate her BMI, and whenever you calculate the BMI of a patient, please calculate it as per pre-pregnancy weight. What is the significance? Because based on her BMI, we are going to advise her how much weight gain is recommended during this pregnancy, right? Then you are going to look at like you do in medicine, the general physical examination, look at whether pallor is present, icterus is present, cyanosis, about lymphadenopathy, and about edema. Now, at what sites are you going to look for edemas? Like you do in medicine, you are going to look at the medial malleolus, then at the anterior tibia, then at the sacrum, and also on the anterior abdominal wall. Now, why I'm saying anterior abdominal wall is because you know that in pregnancy there is physiological edema also. So your examiner can ask you, do you think your patient has physiological edema or pathological edema? Then you will have to tell points in favor of physiological edema and in favor of pathological edema. Now, why is there physiological edema in pregnancy? Physiological edema in pregnancy is because of 2 reasons. Number 1, because of fluid retention. There is so much fluid retention during pregnancy. Around 6.5 liters of water is retained during pregnancy, and that leads to physiological edema. Not only this, what happens is that the gravid uterus, it presses on the lymphatic vessels, and when it presses on the lymphatic vessels, the lymphatic drainage doesn't happen, because of which again it leads to physiological edema. And physiological edema, it is more commonly in the dependent parts of the body, right? So in a pregnant female who's mobile, you are going to get physiological edema in the lower limbs, where you are going to look at the medial malleolus or the anterior tibia. But if your patient is in a bed rest position, right? If she has been advised bed rest, then in that case, the edema will be there on the dependent part, and that is the sacrum. Generally, In case of physiological edema, edema is not seen on the anterior abdominal wall. If you are getting anterior abdominal wall edema, then that generally indicates pathological edema. The other factors which help us in distinguishing between physiological and pathological edema is physiological edema, it is going to subside on rest, whereas pathological edema, it doesn't subside on rest. Physiological edema, it aggravates as the day passes, so it's very prominent or more pronounced during the evening hours or during the later part of the day, whereas pathological edema, it is seen throughout the day. Right? Physiological edema is more common in third trimester because in third trimester uterus becomes large enough to press upon the lymphatic vessels, whereas pathological edema, it can be seen in any trimester. Right now, before you move on and you tell about the thyroid examination and the breast examination, one other very important point which you have to remember is you have to mention whether your patient is comfortable at rest or not. Because if there is uterine over distension, then also your patient will have respiratory discomfort, and you will come to know, and you have to mention that whether she is comfortable or not. And if patient is not comfortable, one reason for her not being uncomfortable, one reason for her not being comfortable was over distension of the uterus. Other reason could be she has some underlying heart problem, and all of you know that in NYHA class 3 and 4, patient is not comfortable. Right? Especially in NYHA class 4, patient is uncomfortable there is dyspnea at rest as well. Right? So now you are going to proceed to breast examination. Many of you as undergraduate students, what you do is you write breast examination normal and you go move forward. Now, this is a point which examiner also knows, that you haven't examined the breast of the patient, right? An examiner is going to ask you, did you examine? And you will say, yes, I examined, although you wouldn't have examined. And just in case your patient has retracted nipples, or if she has cracks or fissures, then you are gone. So it will hardly take 2 minutes to examine the breast. So before you write breast examination normal, please be sure that it is normal. Then write it is normal. Otherwise, if there are cracks or if there are fissures or retracted nipples, please mention them, right? Now, once you are done with general physical examination, now comes the per abdomen examination. Now, before you do per abdominal examination, there are certain prerequisites. Number one prerequisite is that you have to tell your patient to empty her bladder. Without emptying the bladder, you are not going to do a per abdominal examination. Once she's emptied the bladder, you will tell her in her local language what you are going to do. You are going to explain it to her. And if the patient, you've explained to the patient, that is an applied consent that you can go ahead with per abdominal examination. You don't have to take a written consent for any per abdominal examination, right? And then you are going to warm your hands if it is cold, and place your hands gently on the abdomen. Please be very, very gentle with your patients. As a doctor, you have to be really soft-spoken. Your actions should be soft, and you should be an epitome of kindness to the patient. Patient should feel very, very comfortable with you. Patient shouldn't be scared when you come, right? So now you are going to tell your patient to lie in dorsal position with her knees flexed, right? Now, next thing what you have to do is you have to adequately cover and adequately expose your patient. What do I mean by that? Adequately exposed means that the area from the xiphisternum to pubic symphysis should be exposed. Rest all areas should be covered, right? All the other areas you have to cover it. Only the part from xiphisternum to pubic symphysis should be uncovered. Now, you are going to do, first thing will be inspection. Now, when you do inspection, the first thing what you are going to note is whether the abdomen is distended or not. So first thing is you are going to mention abdomen was distended, and you will have to mention whether it is longitudinally distended or whether it is transversely distended. Because if it is transversely distended, that gives you some idea that yes, there may be transverse lie. That's first thing which you are going to mention. Number two, you are going to mention whether any abdominal wall edema is present or not. Number three, mention about the status of the umbilicus. It should be everted. Most of the time it is going to be everted. Then look at the flanks, whether the flanks of the patient are full or whether they are not full. Why? Because when you are going to do palpation, then the fundal height at 32 weeks, it corresponds to fundal height at 40 weeks. Right? In that case, how do I differentiate? One of the ways of knowing whether I am dealing with a 32 weeks pregnant female or a 40 weeks pregnant female is based on frank fullness. If the flanks of the baby, if the flanks of the patient are full, it means this is 40 weeks gestation. If flanks are not full, then that means it is 32 weeks gestation. Clear to all of you? Next, look at any scar marks which are there. Can you see any scar marks? If you do not see any scar marks, mention it in your finding. No scar marks seen, no sinuses seen. The hernial orifices were absolutely normal. No distended veins seen. All this has to be mentioned. Now, once you have noticed this much, then you also have to notice the subumbilical area, this area. Now, in this patient, you can see that the subumbilical area is not flattened. In some patients, subumbilical flattening will be present. Subumbilical flattening, if it is present, it is suggestive of occipito-posterior position or it is suggestive of breech as well. Right? Now what you are going to see? Now you are going to mention about this line over here, which is the linea nigra. Now, linea nigra is a darkly pigmented brown colored line which runs from the umbilicus and it goes up till the pubic symphysis. And why is this linea nigra present? This is because of melanocyte stimulating hormone. You will also comment upon and write it in your findings about these stretch marks, that is the stria gravidarum. This is also something which you are going to mention. So all these things you are going to mention on inspection, right? Once your inspection is complete, now you are going to go to palpation. Now, when you are going to go to the palpation, what are the things which you are going to mention? Now, before you start palpating, I will show you a video just now that how you are going to measure fundal height. But before that also, what you have to do is you have to centralize the uterus, right? For palpating a pregnant uterus, this is very, very important because uterus is dextro-rotated during pregnancy. So you are not going to do any palpation before you centralize the uterus. Now, once you've centralized the uterus, you have to measure the fundal height. You have to see what is the fundal height and to what weeks of pregnancy it is corresponding. Now, again, in the video, I'm going to tell you what is the correct method of knowing the fundal height in a patient, in a pregnant patient. Don't forget to measure the abdominal girth. All of us remember to measure the symphysiofundal height, and we also mentioned about the fundal height. But what we forget is to measure the abdominal girth. Abdominal girth should always be measured at the level of umbilicus. So on palpation, you have to mention the abdominal girth. You have to take the abdominal girth and mention it. You have to tell what is the fundal height of the patient, and then you also have to measure the symphysiofundal height. How you measure the fundal height and the symphysiofundal height in a video clip, I'm going to show you that. Hi everyone, now I'm going to show you how a per-abdominal examination is performed on an antenatal patient. Now, before you do a per-abdominal examination, please instruct your patient to empty her bladder, number one. Number two, explain her what you are going to do. And after explaining, if she's ready for getting the examination done, that's an applied consent which the patient has given you. Now, in which position is the patient going to lie? For per-abdominal examination, patient should be lying in dorsal position with her knees semi-flexed. Now, Before you do per abdominal examination, please see to it that the part between the xiphisternum and pubic symphysis is adequately exposed and rest of the parts are adequately covered. So I have a mommy mannequin with me who has given me an applied consent to perform per abdominal examination. Now, before you start doing per abdominal examination, first I'm going to tell you what are the things which you have to do. There are 4 things which you have to do when you do a per abdominal examination. Number 1, you have to measure the abdominal girth at the level of the umbilicus. Number 2, you have to check the fundal height of the uterus as per the weeks of gestation. Number 3, you have to measure symphysiofundal height, and then you have to go to the obstetrical grips. About obstetrical grips and how to do it, I'm going to show you in the next video. In this video, I'm going to show you how you are going to see the fundal height and how you're going to measure the symphysiofundal height. Now, before you start performing, before you start seeing where the fundal height of the uterus is, be very careful about the fact that uterus is dextro-rotated during pregnancy. So first, with your right hand, you are going to centralize the uterus. That's a very, very important step which you have to do. Do not forget to do this. Then, in order to know the fundal height of the uterus, you are going to use your left hand, the ulnar border of your left hand, and start palpating from the xiphisternum and start coming down. So, palpating downwards from the xiphisternum, the place where you feel the resistance first, that is the place where the height of the uterus is. So, only important thing which you have to remember is you have to centralize the uterus. Starting from xiphisternum, start coming down. You are standing on right hand side of the patient and you're using your left hand's ulnar border. The moment you feel the resistance, wherever you feel the resistance first, that becomes the fundal height of the uterus. Now, if the fundal height of the uterus is at the level of pubic symphysis, this is a 12 weeks pregnancy. If the height of the uterus lies midway between the umbilicus and pubic symphysis, that means that is 16 weeks. It corresponds to 16 weeks of pregnancy. If height of the uterus lies just below the level of umbilicus, that is 20 weeks of pregnancy. Upper border of umbilicus, that is 24. At the level of umbilicus is 22 weeks of pregnancy. Now, if uterus is lying 1/3 distance between the xiphisternum and between the umbilicus, then that corresponds to 28 weeks of pregnancy. 2/3 distance between xiphisternum and umbilicus, that corresponds to 32 weeks of pregnancy, and at the level of xiphisternum corresponds to 36 weeks of pregnancy. After 36 weeks, the head of the baby goes down, and because head of the baby goes down into the pelvis, the height of the uterus decreases, and again it corresponds to 32 weeks of pregnancy. Now, how am I going to differentiate whether it is a 32 weeks pregnancy or a 36 weeks pregnancy? One way of differentiating is on inspection. On inspection, if the flanks of your patient are full, that means this is a 40 weeks pregnancy, right? The other way is you should try to see if you can feel the head of the baby. If head of the baby can be felt per abdominally, that means it is 32 weeks. If head has gone down into the pelvis, that is 40 weeks of pregnancy. So this is how you're going to know about the fundal height. Next thing is, when you are measuring the fundal height, you also have to simultaneously measure the symphysiofundal height. So again, what you're going to do, you are going to centralize the uterus. After centralizing the uterus with your right hand, again with the ulnar border of your hand from xiphisternum, you'll start coming down, and wherever you feel the resistance first, there you are going to mark. Make a mark there, right? So that corresponds to the fundal height of the uterus. Then make a mark at the level of pubic symphysis. Now, once you've done this, you are going to take a measuring tape and you are going to use the centimeter side of the measuring tape. The 0 mark should be put on the pubic symphysis, right? So the 0 mark should be at the level of pubic symphysis, and in straight midline, you are going to measure the symphysiofundal height. Right? So over here, you can see that the symphysiofundal height is coming as 36 centimeters. Between 24 to 36 weeks of pregnancy, the symphysiofundal height in centimeters, it corresponds to the gestational age in weeks. The only thing which you have to remember is that the bladder of the patient should be empty, and you should have centralized the uterus before finding out fundal height or before measuring symphysiofundal height. Right? What is the significance of symphysiofundal height? See, according to NICE 2008 guidelines, symphysiofundal height, it should be measured in all antenatal patients with a gestational age between 24 weeks to 36 weeks. In all such patients, you have to measure symphysiofundal height. Why? Because the symphysiofundal height in centimeters, it corresponds to gestational age in week. Right? So I have to measure the symphysiofundal height in order to know, number one, if the patient doesn't know her gestational age, it is going to help me in knowing the gestational age. Number two, I will have to see whether the symphysiofundal height is corresponding to gestational age or not. Whether the height is more or whether the height is less, they are with different pregnancy conditions which lead to increase in height of the uterus more than the period of gestation and decrease in height of the uterus in comparison to the period of gestation. Right? Now your examiner can ask you, are there any conditions in which you shouldn't be measuring symphysiofundal height? And a common mistake which you people do is that you start telling all those conditions where height of the uterus does not correspond to the gestational age. You start enumerating those reasons, and then your examiner is going to tell you that no, these are the reasons, these are the causes of height of the uterus not corresponding to gestational age. What I am asking is, are there any conditions where your symphysiofundal height should not be measured? Yes, there are 3 conditions in which symphysiofundal height doesn't have any significance. Common sense tells me in transverse lie. In transverse lie, symphysiofundal height doesn't have any significance, number 1. Number 2, in case of over-distended uterus. If I can see that the uterus is over-distended, there is no significance of measuring symphysiofundal height. And number 3, in a known case of fibroid. Right? So in these conditions, there is no significance of measuring symphysiofundal height. Now, suppose the symphysiofundal height is not corresponding to the period of gestation, but then what can be the reason? So what are the reasons where the height of the uterus is more than the period of gestation? Number 1 reason could be wrong dates, and this is something which you people forget. Number 2 could be a full bladder. You start telling all the causes, but the difficult causes, but you forget the basic causes, right? So wrong dates, full bladder, they are very common causes of height of the uterus being more than the period of gestation. And then yes, multifetal pregnancy, polyhydramnios, concealed variety of abruptio, molar pregnancy, macrosomia, diabetes, all these are causes where height of the uterus is more than the period of gestation. What are the conditions in which height of the uterus is less than the period of gestation? So height of the uterus will be less than the period of gestation in intrauterine growth restriction, which these days is called as fetal growth restriction. Then in case of intrauterine death. Then in case of PIH, in PIH IUGR is very common. In case of oligohydramnios, when the amount of amniotic fluid is less, or if premature rupture of membranes has happened. In all these conditions, height of the uterus will be less than the period of gestation. So during palpation, what have I done? I have measured the abdominal girth. I am going to tell the fundal height of the patient. I am going to measure symphysiofundal height, and then I am going to go to the obstetrical grips or the Leopold's maneuvers. Right? Now, Leopold's maneuver is important for all of you, whether you are going to appear for NEET or for foreign medical graduate exams or for INI set or as an undergraduate student. Image-based questions are also asked on Leopold maneuver, so this is very, very important. Leopold's maneuvers, they are done per abdominally, and again I am telling you, patient's bladder should be empty. You have to stand on right hand side of the patient. There are 4 obstetrical grips or 4 Leopold's maneuver which you have to perform, in which the first 3 are done while you are facing towards the face of the patient, and the 4th one is done while you are facing towards the feet of the patient. Right? So let's get going with Leopold's maneuver. The first Leopold maneuver, which is called as the fundal grip. So the first maneuver. Now, in the first maneuver, what are you going to do? In the first maneuver, I am going to take my hands on the fundal area of the uterus. So my face will be facing the face of the patient and my both hands will be on the fundus of the uterus, and that is why it is also called as fundal grip. Now, Leopold's first maneuver tells you about 2 things. Number 1, it tells you about the lie, and number 2, it tells you about presentation. Now, if the first grip or the fundal grip is empty, that means the fetus is lying transversely, right? So that is how it tells you about the lie. If you can feel any part, then that means, if you are feeling either the buttocks or the head, that means it is a longitudinal lie. If you cannot feel buttocks, you cannot feel head, and it feels as if it is empty, then it is transverse lie. Number 1. Number 2, it tells you about the presentation of the baby. So suppose this over here is a baby, right? And this is towards the face of the mother, right? So on fundal grip, if I am feeling a part which is broad, which is irregular and is soft, this means I am feeling the buttocks of the baby, and that means it is cephalic presentation. Right? That means buttocks are facing up and the head of the baby is facing down. Right? So in fundal grip, if you get a broad, irregular, soft part, that means you are palpating the buttocks, and that means it's a case of cephalic presentation. On the other hand, on fundal grip, if you feel hard, firm, globular part, that means you are palpating the head of the baby, and that means it is breech presentation. Right? So the first Leopold maneuver tells you about lie and presentation. It is called as the fundal grip. Then comes the second maneuver. Second Leopold maneuver. Second Leopold maneuver is called as the lateral grip or the umbilical grip. Now what you are going to do, from the fundus, you are going to come to the sides. That means you are going to come laterally. Right? And that is why it is called as the lateral grip or the umbilical grip. Now, look over here. This is what was cephalic presentation. Head is down and buttocks are up. Right. Now, so what I'm going to do while I'm going to do this maneuver, I am going to stabilize the baby with my one hand, and with the other hand, I'm going to palpate. Now, if I am feeling that there is some board-like rigidity, there is smooth, regular, curved part, that means I am feeling the back of the baby, right? So if I feel a board-like rigidity, if I feel the part is smooth, I feel it is curved, that means I am feeling the back of the baby, right? And wherever is the back, at that place is the occiput. Occiput is always towards the back. That means if back is towards left side, occiput will be towards left side. In other words, either the position of the baby is LOA or LOT or LOP, right? That means what is the second grip telling you? The second grip or the lateral grip is telling you about the position of the fetus. So if I am feeling curved, smooth and board-like rigidity, continuous part, that means you are feeling back. So when you are feeling back with one hand, on the other hand, what are you going to feel? On the other hand, you are going to feel limbs of the baby. Limbs of the baby will be multiple small knob-like structures. right? So if back is felt on left side, it is the position of the baby is anything related to left side, LOT, LOA or LOP, right? So there are three positions related to left side. So this over here is the occiput, and whenever you have to tell the position of the baby, you tell it based on the position of the occiput. Right? So wherever is the occiput facing, if occiput is facing on the left side, then the position becomes either LOT, LOA or LOP. If back is on the right side, then the occiput is also on right side, and then the position becomes ROT, ROA or ROP. We cannot tell whether it is ROT, ROP or ROA, which one amongst them. But we know it is one of them. It is either ROT, ROP or ROA. Now, all the undergraduate students who are not understanding what is lie, what is presentation, what is position, then before you try to understand Leopold's maneuvers, you should know the terminology related to labor. And I have given a video in detail on terminology related to labor. So first understand terminology related to labor and then come to Leopold's maneuvers. I'm sure the interns and post-interns, you will understand this terminology well. Right. Then comes Leopold's third maneuver. Leopold's third maneuver, which is called as the Pollock grip. Now, for Leopold's third maneuver, what you are going to do is you are going to put your hand in the pelvic area, right? So, Leopold's third maneuver, which is called as the Pollock grip, it is done with a single hand, and that single hand is placed over the pelvic region. Right? So the single hand is placed over the pelvic region, and what is it going to tell you? It is going to tell you about, the presentation. Now in pelvic grip, if I am feeling that there is a hard, globular, firm structure, then that means it is head, and that means it is cephalic presentation. Now, once I know it is hard, globular, firm structure, I will try to move it from one side to the other side. If I can move it from one side to other side, that is called as ballotable, right? So you are going to try to move it from one side to the other side like this. So if you can move the head from one side to other side, that means head is ballotable, and that means head has not entered into the pelvis. So this is Leopold's third maneuver, or the Pollock grip. Now, as I told you, Leopold's first, second and third maneuver, they are done while you face towards the face of the patient. Whereas Leopold's fourth maneuver is done while you are facing towards the feet of the patient. Right? So now I am going to face towards the feet of the patient, and I am going to perform Leopold's fourth maneuver. Leopold's fourth maneuver is called as the deep pelvic grip. Now what I'm going to do is I'm going to keep both the hands parallel to inguinal ligament. So in images, how are you going to recognize whether it is the third Leopold's maneuver or whether it is the fourth Leopold's maneuver? Third Leopold maneuver is done with a single hand while you are facing towards the face of the patient. Whereas fourth Leopold maneuver is done with both the hands while you are facing towards the feet of the patient. Right? Now what I'm going to do is I'm going to keep my both hands parallel to inguinal ligament, and if my both hands they converge, if there is converging of my both hands below the head of the baby, right, that means head has not entered into the pelvis. Right? So again, what is Leopold's fourth maneuver doing? Leopold's fourth maneuver is confirming the findings of third grip. Number one, with the help of Leopold's maneuver, you can come to know what part you are feeling. If you feel a part which is hard, which is firm, right? And which is globular. It means it is the head you are feeling. So it is confirmed that yes, it is cephalic presentation. And now you try to take your hands below the head of the baby. If your hands can go below the head of the baby, if your hands converge below the head of the baby, that means it is the head of the baby has not entered into the pelvis. So yes, what is Leopold's fourth maneuver doing? It is helping you to confirm the findings of the fourth maneuver. Please don't call it of the third maneuver. Please don't call it as the third grip. It helps you in confirming the finding of the third maneuver. Right? Third maneuver was called as Pollock grip, and the fourth maneuver is called as deep pelvic grip. Now there is one additional thing which Leopold's fourth maneuver is going to tell you, and it is going to tell you about the attitude of fetal head. Now, before we go on to the attitude of fetal head, remember that there are two very important landmarks which are present on fetal head. One is the sinciput. What is sinciput? Sinciput is the part where frontal bones are meeting the face. So this part over here is the sinciput. And then we have an occiput. What is occiput? Occiput is the part below the posterior fontanelle and foramen magnum. Now, all of you understand that there are two important parts, sinciput and occiput. Sinciput is the place where the frontal bones, it meets the face. This part is the sinciput. And the part posteriorly below the posterior fontanelle, that will be the occiput. Now, another very important point is that both anterior fontanelle and posterior fontanelle, they have very different shapes, right? Anterior fontanelle is diamond shaped and posterior fontanelle is triangular shaped. So sinciput, it lies anterior to the anterior fontanelle, and anterior fontanelle is diamond shaped, right? Whereas occiput lies posterior to the posterior fontanelle, and posterior fontanelle is triangular in shape, right? So now, how is the fourth Leopold maneuver going to tell you about the attitude of the baby? First, tell me, what is attitude of the baby? Attitude is the relationship between different parts of the baby. What is attitude? Attitude is relationship between different parts of the fetus, right? And the most common attitude is that of flexion. So mostly all the parts of the fetus are flexed. The head of the baby is flexed, the hands of the baby are flexed, and the legs of the baby are also flexed, right? So this is the most common attitude. All parts of the baby are flexed, right? That is the attitude. So now, with the help of Leopold's fourth maneuver, I can come to know what is the attitude of the baby, whether the head of the baby is flexed, or whether the head of the baby is deflexed, or whether the head of the baby is extended. Like this, it is flexed. Like this, it is deflexed. And like this, it is extended. Till here it is clear to you. Have you understood what is sinciput? Sinciput is the part where the frontal bone is going to meet the face. That is sinciput. And where it is lying anterior to the diamond-shaped fontanelle. What is occiput? Occiput is posterior to the posterior fontanelle, which is triangular fontanelle. Clear? Now imagine this is how the baby is. Right? Now tell me. First tell me, before even we flex the baby, before anything, tell me, where does occiput lie? As I told you just now, occiput always lies towards the back of the baby, right? So the occiput will always be towards the side where the back of the baby is, right? Now, understand. So now, the head of the baby is completely flexed and it is lying like this. Now, imagine that mother's face is towards my side and mother's feet is towards your side. It is towards the camera side, right? So I am facing towards the mother's head, and the other side is mother's feet, and this is how this baby is lying in the mother's uterus. Now, because I am towards the head end of the mother, so towards the head end is the buttocks, and towards in the lower part of the uterus of the mother, you are going to get the head. That means it is cephalic presentation. So feet is facing towards the upper side and the head is facing towards the lower side. That means it is cephalic presentation. And the head of the baby is completely flexed. Now, in a completely flexed head, when I am going to go do a per abdominal examination, so I am doing a per abdominal examination and I am trying to feel the anterior fontanelle and the posterior fontanelle. This is my hand on posterior fontanelle. This is my hand on anterior fontanelle, right? Now, I am trying to feel the posterior fontanelle and I am trying to feel the anterior fontanelle. Anterior to the anterior fontanelle is the sinciput. Now, as you can see, that sinciput, when I am doing a per abdominal examination, sinciput is lying at a higher level. This hand is at a higher level. So, this is sinciput, right? So, this pen is pointing towards the sinciput and my finger is at the occiput. Can you see? So, sinciput will be in a well-flexed head. Sinciput will always be felt at a higher level on per abdominal examination and occiput will be felt at a lower level because the head of the baby is completely flexed. So, I am completely flexing the head of the baby. So, because the head of the baby is completely flexed, the sinciput is lying at a higher level and occiput is lying at a lower level. How am I going to know this is occiput and this is sinciput? I am going to know this is occiput and this is sinciput because I am going to feel the fontanelles. The point which is lying closer to the triangular fontanelle is the occiput and the point which is lying closer to anterior fontanelle is the sinciput, right? The diamond shaped fontanelle is the sinciput, the triangular fontanelle is the occiput. So if I can feel that the point which is lying closer to the diagonal fontanelle is felt per abdominally at a higher level, right, than the point which is closer to the triangular fontanelle, I will say, okay, the head of the baby is well flexed. This is on per abdominal examination and Leopold's maneuver is a per abdominal examination, right? Now imagine the head of the baby is extended. Now the head of the baby is extended. Now I start doing per abdominal examination. Now what am I going to feel? Now I am going to feel that the occiput is at a higher level, right? I can feel the occiput at a higher level and I have to go down and then I will feel the sinciput. So if you are feeling occiput at a higher level and sinciput at a lower level, that means head of the baby is extended. The other difference. Now, when the head of the baby was flexed, right, occiput was felt on one side and on the other side you were feeling the sinciput. Both occiput and sinciput were not felt on the same side. And because they are not felt on the same side, that means head of the baby is flexed. Whereas, if the head of the baby is extended, both occiput and sinciput will be felt on the same side. Occiput at a higher level and sinciput then at a lower level. But both of them will be felt on the same side as that of the back of the baby, right? So then you come to know that head of the baby is extended. Are you understanding this? Now suppose head of the baby is deflexed. Now if head of the baby is deflexed, I will feel occiput and sinciput at the same level. Right? So if occiput and sinciput are felt at the same level on opposite sides, then that is a deflexed head. Always in a flexed head, whether it is deflexed or fully flexed, occiput and sinciput will be on different sides. Always in an extended head, occiput and sinciput will lie on the same side. Right? So clinical questions can be asked in this manner. So now I want all of you to understand and read what I have written over here. What the relationship of sinciput and occiput during fourth maneuver tells us about the attitude of the fetus. In a well-flexed head on per abdominal examination, occiput is felt at a lower level. So this is occiput and this over here is sinciput. So sinciput will be felt at a higher level and occiput will be felt at a lower level. Yes, and both will be felt on the opposite sides. Both are on opposite sides. Then you come to know that yes, it is a well-flexed head. Right? Now, whereas if the head of the baby is extended, if head of the baby is extended, this is the occiput, this is the sinciput. When I will do a per abdominal examination, occiput is at higher level, right? And sinciput is at lower level. Right? And both are felt on the same side. Both felt on same side. Then I come to know that yes, it is extended head. In case of a deflexed head, both sinciput and occiput, they will be at the same level. Have you understood? This is on per abdominal examination. So if I ask you, what is Leopold's fourth maneuver doing? You will say it will confirm the findings of third. It will confirm the findings of the third maneuver. Right? And what findings? It will tell you about the presentation, which the third maneuver was also telling, and it tells you whether the head has entered the pelvis or not. Entered the pelvis or not. And how was it telling you? I told you that you have to keep your fingers parallel to inguinal ligaments, and then if your hands get converged below the head of the baby, that means head has not entered the pelvis. Right? So now when you'll see a video, you will understand everything. First thing, it confirms the findings of the third maneuver, and second thing, it tells you about the attitude of the fetus. So these are the things which Leopold's fourth maneuver is doing. It is telling you about presentation. It is telling you whether the head of the baby has entered the pelvis or not. That is, it is confirming the findings of the third maneuver. And simultaneously, it is also telling you about the attitude of the fetus, right? So all this is when you do a per abdominal examination. Now I'm going to show you a video clip on how Leopold's maneuver is done. I'll practically do Leopold's maneuver and I'll show it to you. Okay? Hi students. Now I'm going to show you how obstetrical grips or the Leopold's maneuvers are performed. And again, the same thing which I told you while you have to do measure the symphysiopundal height, same instructions you have to keep in mind. Patient's bladder should be empty before she lies down. Patient's part between the xiphisternum and between pubic symphysis, it should be adequately exposed. Position of the patient should be lying supine with the knees semi-flexed. You should have explained to the patient in her local language what you are going to do. And then you are going to stand on right side and you'll start performing the Leopold's maneuvers. The first three Leopold maneuvers are done while facing towards the face of the patient. And the fourth Leopold maneuver is done when you're going to face towards the feet of the patient. So we're going to start with the Leopold's first maneuver, which is also called as the fundal grip. Now for Leopold's first maneuver, you are standing on the right hand side of the patient, your face is towards the face of the patient, and with your both hands you are going to gently feel what you are feeling at the fundus of the uterus. Now this is Leopold's maneuver first, or it is also called as the fundal grip. Now all of you know that in most of the times the lie of the baby is longitudinal, and if lie of the baby is longitudinal, then you are going to feel either the buttocks or you are going to feel the head of the baby at the fundus. Now, since cephalic presentation is the most common presentation, maximum times what you're going to feel, you are going to feel buttocks. And how are the buttocks felt? Buttocks feel as if they are soft, broad and regular. So if you feel something which is soft, broad and regular, that means you are feeling the buttocks of the baby, and that means this is a cephalic presentation. On the other hand, if you feel a firm globular structure, that means you are palpating the head of the fetus, and that means head of the fetus is at the fundal area. In other words, it's a breech presentation. So first, fundal grip tells you about the presentation of the fetus. Also, it tells you about the lie of the fetus. Because if you are feeling either the buttocks or the head, that means it's a longitudinal lie. If you are not feeling buttocks or if you are not feeling a head, that means it's a transverse lie or it could be an oblique lie, right? Then from the fundus of the uterus, now you are going to shift your hands gradually to the lateral side of the uterus. This is what is called as the lateral grip, or this is also called as Leopold's second maneuver. Now you are going to stabilize your hands. On one side you are going to stabilize the fetus, and with the other hand you are going to palpate. Now if you are feeling smooth, curved, board-like structure, continuous smooth curve board-like structure, that means you are feeling the back of the fetus, right? So this means that I am feeling the back of the fetus on left side. And if back of the fetus is on left side, then position of the fetus will be either LOT, LOA or LOP. Now once I have felt back on this side, I'm going to stabilize my hand on the left side, and with the right hand I'm going to palpate what I'm feeling. Now on the right hand side you will feel multiple knob-like structures, small tiny knob-like structures. That means you are feeling the limbs, right? So on one side you are going to feel something which is broad, smooth, curved with a board-like structure. On the other hand, you are going to feel multiple small irregular knob-like structures. The side where you feel board-like continuous structure, that is where the back is, and the side where you feel multiple small knob-like structures, that is where the limbs of the baby are. So Leopold's second maneuver or Leopold's second grip, that is the lateral grip, or it is also called as the umbilical grip, tells you about the position of the baby. If back is on the left side, position can be LOT, LOA or LOP. And if back is on the right side, then position will be ROT, ROA or ROP. Now you are going to take your one hand and you are going to place the ulnar border of your right hand on the pubic symphysis. Make a cup of your hand and feel what you are feeling at the lower part of the uterus. Now, this is what is called as the Leopold's third maneuver or Pollock grip. Again, you are facing towards the face of the patient still. Right, now Leopold's third maneuver, if suppose in Leopold's third maneuver you are feeling firm, rounded, globular structure, that means you are feeling the head of the fetus. It means it's a cephalic presentation. So Leopold's third maneuver, what does it tell you? It tells you about the presentation. So once I know that yes, I am feeling the head of the baby, now I'll try to see whether the head of the baby can be moved from side to side. This is how I'm going to check whether the head of the baby can be moved side to side. This is what is called as ballotable. If head of the baby can be moved from side to side, that means head has not yet entered into the pelvis. That means it's a free head just now. If you cannot move the head from side to side and the head is fixed, then that means the head has entered into the pelvis. So let me show you. See over here. if you can move the head from side to side, right? This is what is ballotable, and this means head is free floating. The moment head goes down into the pelvis, you will not be able to move it from side to side, right? I hope this is clearly visible to you. Yes? So now the head has gone into the pelvis. Now it cannot be moved side to side, and that means head of the baby is fixed. Is this clear? This is how Leopold's third maneuver, which is called as the Pollock grip, is performed. Now, once you've performed the Pollock grip, now you are going to face towards the feet of the patient. And while facing towards the feet of the patient, you are going to perform the fourth maneuver, which is called as the deep pelvic grip. For performing the deep pelvic grip, you're going to use your both hands and you are going to place them parallel to the inguinal ligament. And then you will try and palpate what are you feeling. Again, if it is cephalic presentation, you will feel a hard, firm, globular structure. So if you feel a hard, firm, globular structure, that means it is cephalic presentation. And that means the fourth maneuver is confirming the findings of the third maneuver. Not only this, now what I'm going to do is, again, I'm going to check whether the head of the fetus has gone down into the pelvis or it is still in the abdomen. So again, for that, I am just going to open and I'm going to show it to you so that the concept is clear to you. So look over here. Again, when you are doing Leopold's fourth maneuver, you have to keep both the hands parallel to inguinal ligament, and you will try to bring them below the head of the fetus. If your both hands get converged below the head of the fetus, that means head has not yet entered the pelvic cavity. That means head is not fixed. Suppose the head of the baby is fixed. Now the head of the baby has entered into the pelvic cavity. Now if I try to go below the head of the fetus, my hands cannot go below the head of the fetus and my hands will diverge. Look again. This is the head of the fetus, which is in the abdominal cavity. It has not yet entered the pelvis. So now if I try to bring my hands below the head of the fetus, both the fingers of my hands can converge, right? So my fingers of both the hands, they converge below the head of the fetus. This means that head has not yet entered the pelvis. Now, let this head of the baby go inside the pelvis. Now, once the head has gone inside the pelvis, I cannot take my hands below the head of the baby, right? So my hands will not go below the head of the fetus and they will diverge. Right? So let us cover it here. Now, if I try to take it, my hands will diverge. I cannot take my hands below the head of the fetus and my hands are going to diverge. This is how you perform the deep pelvic grip or the Leopold's fourth maneuver. So Leopold's fourth maneuver, it helps in confirming the findings of the third maneuver. But then it gives one more additional information, and that is about the attitude of the fetus. So now, as I told you, in order to know about the attitude of the fetus, there are two very important prominent bony landmarks which we have to feel. So over here is our baby mannequin, and in this baby mannequin, this over here, see this diamond shaped is the anterior fontanelle. Now just in front of the anterior fontanelle is the sinciput, where the frontal bones, they meet the forehead. That is what is sinciput. Now over here at the back, the triangular shape is the posterior fontanelle, right? And the most prominent point over the posterior fontanelle is the occiput, right? So over here we have the sinciput, and over here we have the occiput. Important point to note is that occiput is lying in line with the back of the baby, right? So wherever is the occiput, at that side is the back of the baby, right? Now, Now I want all of you to see how we come to know the attitude of the baby. Now, so that you understand better, I have placed a blue thumbpin at the level of the occiput and a red thumbpin at the level of the sinciput. Don't worry, the fetus is not going to cry. I have given local anesthesia, so not to worry. Now, because you so that you understand, ideally, see, all the maneuvers, they should be performed while you are standing at the right side of the patient. But so that it is clearly visible to you and I can make you understand, I am standing on the left-hand side of the patient. Now, suppose the head of the baby is fully flexed. Now, see over here. Can you see the red thumbpin and the blue thumbpin? Now, in a fully flexed head, you can see that occiput is lying at a lower level and sinciput is lying at a higher level. When I will do per abdominal examination, I will feel the sinciput first and then I am going to feel the occiput. Right? And the other thing which you have to note is that occiput and sinciput, they are lying at different sides. Now you will say that, ma'am, how did we come to know that this is occiput and this is sinciput? Then I'm sure you've heard the video first and I told you the most prominent bony point which lies near the triangular fontanelle is the occiput and the one which lies near the diamond shape fontanelle is the sinciput. So when I will do a per abdominal examination and if I feel that, okay, occiput is at lower level and sinciput is at higher level, sinciput is the first bony point which I feel, then I come to know that head of the baby is fully flexed. Can you see? Head of the baby is fully flexed in this condition. Okay. Now, suppose the head of the baby is extended like this. Now, if head of the baby is extended and I am doing a per abdominal examination, my fingers will first touch or palpate the occiput. So now you've seen how Leopold's maneuvers are done and I hope everything is clear to all of you.